Dear doctors, on World Hypertension Day, we have organized three online lectures to provide you with valuable insights and updates on hypertension management. Our first lecture will focus on isolated systolic hypertension in the elderly. This lecture will cover the prevalence and diagnosis of isolated systolic hypertension in elderly patients. Our expert speaker will also discuss the treatment options available, including lifestyle modifications and pharmacological interventions. Now, the second lecture will explore hypertension in children. Our speaker will discuss the prevalence of hypertension, risk factors, potential complications. We will also examine the diagnosis and management of hypertension in children, including non pharmacological and pharmacological interventions. Our third and final lecture will tackle the challenges in hypertension management. This lecture will cover the management of hypertension in patients with comorbidities, such as diabetes or chronic kidney disease. We will also discuss the challenges of patient adherence to treatment and explore ways to improve patient outcomes. Now, all three lectures are designed to be interactive and engaging, enabling you to ask questions and participate in the discussions with our expert speakers. We would also like to believe that these lectures will provide you with valuable insights and practical strategies to improve the management of hypertension in your practice. I urge you to participate actively in these lectures and make the most of this opportunity to learn from our experts and engage in meaningful discussions. Together, let us work towards raising awareness about hypertension and its management and strive towards better health outcomes for our patients. Thank you, and I look forward to your participation in these lectures. Welcome to the first lecture for World Hypertension Day. We shall be talking about isolated systolic hypertension, which is one of the most common forms of hypertension among the elderly. Now, increased calcium and collagen deposition on the arterial walls causes an increase in the pulse pressure, which causes the systolic blood pressure to rise and diastolic to reduce. This leads to the development of isolated systolic blood pressure, which is like hypertension and can cause end organ damage if left untreated. It is imperative to diagnose this entity at a very early stage, identify the risk factors, and induce prompt treatment to reduce mortality and morbidity in the elderly population. So, to talk about this, we have with us Dr. Shubhangi Kantikar. Welcome, ma'am. She is the professor and head of the Department of Medicine at Dr. D.Y. Patil University in Pune. She has also guided many PG and PhD students for their research. Along with being the in charge of a geriatric clinic, she is also the executive member of the Geriatric Society of India, Pune branch. She's also the founder member and secretary of the Pimpri-Chinchwad branch of API, which is the Association of Physicians of India. Dr. Kantikar has been a member of International Advisory Board for MacLeod's textbook of clinical examination, 13th edition. She's also contributed many publications in many international and national journals. Ma'am, it is an absolute pleasure to hear you today. Please throw some light on isolated systolic hypertension in the elderly. Over to you.
Good afternoon. I will be speaking on isolated systolic hypertension in the elderly. Hypertension is a common problem in older adults. Isolated systolic hypertension is the predominant form of hypertension in the elderly population. Traditionally, it has been defined as a systolic blood pressure above 140 millimeters of mercury with a diastolic pressure of less than 90 millimeters of mercury. The prevalence of isolated systolic hypertension increases with age, and it is estimated that 30% patients above 60 years, that is about 1/3, and 3/4 of the persons more than 75 years have isolated systolic hypertension. And as per data from the Framingham Heart Study, normotensive patients who have reached the age of 65 years, they will have a 90% risk of developing isolated systolic hypertension if they live further for about 20 years. So, as we all know, that the elderly population is increasing, and so isolated systolic hypertension remains an important public health concern as chronically high blood pressure patients, they carry a significant mortality and morbidity. The objectives of today's talk will be, first, we will be defining the hypertension and isolated systolic hypertension. and the factors that contribute to the systolic hypertension in the elderly. Then the investigations in a patient with systolic hypertension and the management strategies for the isolated systolic hypertension. Coming to the classification. According to the guidelines issued by the European Society of Cardiology and the European Society of Hypertension in August 2018, isolated systolic hypertension is defined as a systolic blood pressure more than 140 millimeters of mercury and a diastolic blood pressure less than 90 millimeters of mercury. Now, coming to the various grades of hypertension, the optimal blood pressure that one should have is less than 120 systolic millimeters of mercury and less than, so it should be less than 80. The normal blood pressure is defined as systolic between 120 and 129 and a diastolic between 80 to 84. The high normal systolic between 130 to 139 and a diastolic between 85 to 89 millimeters of mercury. A systolic blood pressure of 140 to 159 and a diastolic blood pressure of 90 to 99 millimeters of mercury is graded as grade 1 hypertension. Systolic blood pressure 160 to 179 with a diastolic of 100 to 109 is graded as grade 2 hypertension, and systolic blood pressure of more than 180 and a diastolic blood pressure of more than 110 millimeters of mercury is graded as grade 3 hypertension. Isolated systolic hypertension is systolic blood pressure above 140 millimeters of mercury and a diastolic below 90 millimeters of mercury. The American Heart Association, as per their guidelines issued in 2017, have classified a systolic blood pressure of 130 millimeters of mercury. It is considered that a systolic blood pressure of more than 130 millimeters of mercury is considered hypertensive for all ages. The isolated systolic hypertension itself can be classified into 3 classes based on the systolic blood pressure measurement. Systolic blood pressure between 140 to 159 millimeters of mercury is graded as grade 1. Systolic blood pressure 160 to 179 millimeters of mercury is grade 2, and systolic blood pressure above 180 millimeters of mercury is grade 3. An important point regarding how the readings should be taken to have the correct measurement for the blood pressure. Readings should be taken after the patient has been resting comfortably, back supported in the sitting, or the patient can be in the supine position for at least 5 minutes. And at least 30 minutes should have passed if he has smoked or consumed coffee. A single blood pressure reading is not sufficient to establish the diagnosis of hypertension. 2 readings should be taken 5 minutes. Many a time, if the blood pressure is measured in the clinics, the blood pressure records is little higher. So, and this is known as the white collar hypertension. So, blood pressure measurements can be taken outside the office environment, either by intermittent self-monitoring, that is known as the home blood pressure recording, or it can be taken with an automated device programmed to take measurements at regular intervals, and this is known as the ambulatory blood pressure monitor. Coming to the pathophysiology of isolated systolic hypertension. Isolated systolic hypertension can develop due to increase in the systolic blood pressure, which happens because of increased arterial stiffness in previously normotensed individuals. With increasing age and progression of atherosclerosis, there is increased deposition of calcium and collagen in the walls of the blood vessels, and there is a fraying of the arterial elastin. The result is there is a reduction in the arterial elasticity and a reduction in the compliance. This leads to increased arterial stiffness. Due to this, there is loss of contractility, proliferation of the smooth muscle cells, and the fibrotic remodeling of the vascular intima, and all these things will increase the vascular thickening. These changes occur mostly in the large arteries and in the aorta. Now, the non-compliant stiff arterial tree leads to a very fast rise in the peak blood pressure, whereas because of the stiffness, there is a limited recoil, and this causes a greater decline in the diastolic blood pressure. So this graph here, it shows that as the age advances, the systolic blood pressure rises. So here we can see at the age of 40 to 49 years, this is the systolic blood pressure. It is below 130, but below about the age of 70, it is risen. But the diastolic blood pressure, till the age of about 59 to 60 years, the diastolic blood pressure rises, but above the age of 60, there is a fall in the diastolic blood pressure, leading to a wider pulse pressure and an isolated systolic hypertension. This picture also shows the aorta in a normal person and a younger person, and here is the aorta in an elderly person, which is a non-compliant. Here, during the systole, because of the compliance, there is a distension in the balls, and during the diastole, there is a recoil. Whereas in this non-compliant vessel, because of the stiffness, there is no elasticity. So during the systole, the blood pressure will rise, and during the diastole, there is no recoil. So there is a quick run back, and the diastolic pressure will fall. And this is the pulse rate, which shows a rapid rise and a fall. The clinical features of isolated systolic hypertension, but they will be very similar to whatever findings we had in a patient with hypertension. But it is important to know that usually patients with hypertension are asymptomatic. Most of them are asymptomatic, and it is not known that they are hypertensive till a diagnosis is made either on a routine physical examination or whenever they visit a doctor for some other medical issue. And when the blood pressure is checked, it is found that the blood pressure is high. Very, very few people, they will have some symptoms such as headache or a vague feeling or a fatigability, but usually hypertension is usually asymptomatic. Reflecting on this fact, a regular blood pressure check is advisable in all adults over the age of 40 years, which will help in picking. Whenever an examination of a patient with hypertension is done, it may also reveal evidence of risk factors such as obesity and hyperlipidemia. Some of the signs may be observed. It could be because of the complications of the high blood pressure. These include signs of left ventricular hypertrophy. Severe hypertension can cause left ventricular failure, and sometimes there can be complications like stroke. So patient can sometimes just present with stroke. He may have never checked his blood pressure, and whenever he's brought to the hospital with a stroke, it may be found that he has had hypertension. The fundus examination also in a patient with hypertension is abnormal and may show evidence of hypertensive retinopathy. Sometimes these clinical features may be observed, and usually they are found in patients whenever there is an underlying cause of hypertension, which is also known as the secondary hypertension. These clinical features could be radiofemoral delay in patients with coarctation of aorta, enlarged kidneys in patients with polycystic kidney disease, abdominal bruits that may suggest renal artery stenosis, and a characteristic facies and habitus in a patient of Cushing's syndrome. Whenever we are evaluating a patient with hypertension and even isolated systolic hypertension, a relevant history such as family history of hypertension and cardiovascular disease, a diet history, history of alcohol consumption and smoking, risk factors such as obesity, dyslipidemia, diabetes, physical inactivity should be sought for. Evidence of target organ damage can be obtained in the history, such as history of a transient ischemic attack, stroke, or a history of a myocardial infarction. By physical examination, it is important to check the height and weight in order to calculate the body mass index, blood pressure in the supine, the standing position, to know for the orthostatic hypotension, fundoscopic examination of the retina, heart rate and rhythm, and signs of congestive heart failure should be looked for. A person should be investigated first by the baseline investigations, which include urine analysis of blood, protein or glucose, blood urea, electrolytes and creatinine, a blood glucose level, total and HDL cholesterol in the serum, thyroid function tests, and an ECG, which can show about ischemic heart disease and any left ventricular hypertrophy. Specialized investigations can be done, which include X-ray of the chest to detect cardiomegaly, heart failure, and the coarctation of to detect or quantify the left ventricular hypertrophy. Renal ultrasound to detect possible renal disease. Renal angiography to detect or confirm the presence of renal artery stenosis. Some other investigations like urine catecholamines, urinary cortisol, and the dexamethasone suppression test, the plasma renin activity and aldosterone can be done if indicated. Like if there is a possibility of a pheochromocytoma, the urinary catecholamines can be checked. If there is possibility of a Cushing's syndrome, the urinary cortisol and the dexamethasone suppression test may be done, and to detect possible primary aldosteronism, plasma renin activity may be done, but all these tests are not needed if not indicated. Now, once the diagnosis of isolated systolic hypertension has been and the person is being investigated, one should know why the blood pressure, the systolic blood pressure should be brought down. In the olden days, it was believed that in the elderly, the systolic blood pressure is high, and that is a part of the normal aging. And there is no need to bring down the systolic blood pressure. But then there is a lot of evidence. Many trials have been conducted which show the beneficial effects of treatment of isolated systolic hypertension. The systolic hypertension in the elderly program, that is the SHEP study, was the first clinical trial to demonstrate beneficial effect of treatment of isolated systolic hypertension. When the systolic blood pressure was reduced by approximately 26 millimeters of mercury, it was found that there was a significant reduction in the stroke in patients. This was about 36% reduction. There was a reduction in the coronary heart disease by 25% and a reduction in the heart failure by 49%. Many other such important trials which showed benefits of treatment. They include the systolic hypertension in Europe study, the systolic hypertension in China study, the Swedish trial in old patients, and the hypertension in the very elderly patients. This has proved that reducing systolic blood pressure is very important in the elderly with isolated systolic hypertension. The treatment that we can give can be divided into the non-pharmacological therapy and the pharmacological therapy. The goals. The 2018 European Society of Hypertension, the European Society of Cardiology, these guidelines, they specify a target of less than 140 millimeters of mercury systolic for all, and if in those who can tolerate, even a systolic of less than 130 millimeters of mercury. So, treatment should be initiated if the blood pressure exceeds. Patients with diabetes or cardiovascular disease are at a particular high risk, and threshold for initiating treatment is lowered at 130 systolic in these patients. Then there are ways by which one can do a formal estimate of the cardiovascular risk, and this estimate takes account of the risk factors. So this is helpful in the initiation of treatment. Now, when there are patients with systolic blood pressure between 130 to 139 millimeter of mercury, how do we go about? What do we do? So, in these patients, we can divide it then into two groups. The first is patients without any atherosclerotic cardiovascular disease, ischemic heart disease, or there is a risk score known as the ASCVD risk, which can calculate the 10-year risk. So if this risk is less than 10%, we can initiate non-pharmacological therapy for these patients and we assess in about 3 months. Whereas a patient who has atherosclerotic cardiovascular disease or a 10-year ASCVD risk greater than 10%, we initiate non-pharmacological therapy, and along with this, we add a oral antihypertensive agent and we reassess the patient in a month. If the systolic blood pressure is more than 139 millimeter of mercury, we have to initiate non-pharmacological therapy along with a single oral antihypertensive agent, and we have to reassess the patient. If the blood pressure goal is not met, we have to assess and optimize adherence to therapy or to consider the intensification of the therapy. Coming to the non-pharmacological methods and for treatment of hypertension, they are the lifestyle modifications for the control of blood pressure. Some of them are weight loss. So, what is the intervention? We should target the body mass index to be between 18.5 to 24.9. And if there is obesity or the BMI is more than 24.9, we have to encourage the person to have weight loss, of course, under supervision. And it is found that there is a decrease in 5 to 20 millimeters of mercury blood pressure, systolic blood pressure, with about 10 kg weight loss. The DASH diet, that is the dietary approach to stop hypertension. So this comprises of fruits and vegetables along with the low-fat dairy products. And this also helps in bringing down the blood pressure. Decreasing sodium intake to less than 6 grams salt per day also helps in bringing down the blood pressure. So the patients are encouraged not to have the salt on their dining table. So whatever the salt they take by having their food, the extra salt should be avoided. Also, the foods that contain high salt, such as dairy products, products from the bakery, and pickles and such other products should be avoided. Decreasing alcohol intake also helps in resulting decreasing in the blood pressure. Exercise like walking, because most of these patients are elderly. Exercises should be done only under supervision and after informing the treating doctors. But one of the good exercises is walking about 30 minutes per day, which will help to bring down the blood pressure. Mindfulness, meditation, and breathing control also helps in bringing down the blood pressure. So these are few of the lifestyle modifications that can be practiced. Now, coming to the pharmacological treatment, some of the general guidelines are antihypertension should be started with a lower initial doses to minimize the risk of the side effects. If hypertension emergency is not there, that is very high blood pressure, the blood pressure should be lowered gradually. Even this will minimize the risk of the ischemic syndrome symptoms, particularly in patients with orthostatic hypotension. When treating frail elderly patients, extra caution should be taken in the setting of orthostatic hypotension to avoid over-treating them, because it is seen that orthostatic, the postural hypotension, is found in as many as 20% of elderly patients with isolated systolic hypotension. And this postural hypotension can lead to falls and can lead to the increased risk of having hip fractures during the initial therapy. So this can be avoided if we are monitoring for the postural hypotension. 3 classes of drugs are considered as the first-line treatment for the hypertension in the older adult patients. The first one being the calcium channel blockers. The efficacy and safety of long-acting calcium channel blockers in treating elderly hypertensive patients have been proven and demonstrated in various trials. The thiazide diuretics are the second group, which are recommended as an initial drug therapy for most patients with isolated systolic hypertension due to their higher efficacy in reducing the blood pressure. The third group is the angiotensin converting enzyme inhibitors, that is the ACE inhibitors, and the angiotensin receptor blockers, or the ARBs. Many elderly hypertensive patients have specific indications for the ACE inhibitors or the ARBs, and these are arterial, myocardial infarction, and the presence of diabetes. So these drugs are very useful in these settings. Now, management of the isolated systolic hypertension according to the grades of the isolated systolic hypertension. So whenever a person with grade 1 isolated systolic hypertension, what we can advise is the lifestyle modifications, monitoring the blood pressure regularly. But if the blood pressure is not at goal, it's not coming down, we can start a single drug therapy, either a calcium channel blocker, thiazide, or a ACE inhibitor, or a ARB. For grade 2 or grade 3 isolated systolic hypertension, again, lifestyle modifications do play an important role, but we can go in for a combination of a 2-drug therapy, which can be either a calcium channel blocker with a thiazide or a ACE inhibitor, or a ACE inhibitor ARB with a thiazide. If the blood pressure is not controlled, a third drug may be added according to the indications. Then there is something known as the compelling indications, like there are some situations where of these drugs, some will be preferred. For example, ACE inhibitors can be preferred in the heart failure. Post myocardial infarction, we can add beta blockers. A person with diabetes, we can add ACE inhibitors along with the CCTs. What is the importance of the diastolic blood pressure when we are treating patients with isolated systolic hypertension? We all know that when we treat the systolic blood pressure, even the diastolic blood pressure is going to come down. But how low or till what level of diastolic pressure can be treated? There are no clear data that provide guidance related to the minimal diastolic blood pressure that can be tolerated. So some studies have been done, and an analysis from the SHUT trial found that when the diastolic pressure was brought down below 60 millimeter of mercury, there was a significant increase in the adverse effects in the form of cardiovascular events in the group that was being treated. A similar, this is known as a J curve. So initially there will be benefits, and below a certain level, there will be more side effects. So similar J curve was also noted in some other studies, like the Rotterdam study showed an increase in the stroke rise that began when the diastolic pressure went below 65 millimeter of mercury. Another study, the INVEST study, they found that patients with coronary artery disease, an increased risk of myocardial infarction began when the blood pressure was between 60 to 70 millimeters of mercury. And if the blood pressure was the diastolic blood pressure, and if this diastolic blood pressure was brought below 60 millimeter of mercury, there was still 2.5-fold rise in the events of myocardial infarction. So, cardiovascular events can occur if diastolic blood pressure is reduced below the level to maintain perfusion to vital organs, particularly the heart. Similarly, other side effects such as stroke can also occur. So, it is suggested that a minimal post-treatment diastolic blood pressure of 60 millimeter of mercury be maintained. Coming to this summary, isolated systolic hypertension is common in the elderly population because aging changes the conduct in the arteries. Systolic blood pressure is a significant risk factor for cardiovascular and renal disease. Lifestyle modifications are the primary treatment and should be insisted on every visit of an elderly hypertensive individual. Except in a situation of hypertensive emergency, start slow, go slow, and be gradual to achieve the best target BP level with maximum tolerable drugs and doses without side effects. A potential limiting factor to the use of antihypertensive drugs is the orthostatic hypotension, which is common in the elderly. There is no indication for a specific antihypertensive drug. Initially, monotherapy with a long-acting calcium channel blocker, a thiazide diuretic, or an ACE inhibitor or an angiotensin receptor blocker is recommended. If additional therapy is required, another group of drug in incremental doses can be added. So to conclude, isolated systolic hypertension is increasing in prevalence as the population of elderly increases. It is an important risk factor for cardiovascular and renal diseases. The basic pathology is increased arterial stiffness, and several trials have shown benefit even in the elderly for treating the isolated systolic hypertension. Very low diastolic blood pressure is a concern, but studies have shown no adverse effects up to a diastolic blood pressure of 60 millimeters of mercury. Calcium channel blockers and diuretics are the drugs of choice. Thank you.
Thank you so much, Dr. Kantikar, for such an insightful lecture. We have some questions for you, ma'am. So my first question is, how does the primary care physician contribute to the management of ISH?
The primary care physicians play a very important role in detecting and managing isolated systolic hypertension. Because as we have already seen that most of the time, the patients never have any symptoms whenever they have hypertension. So whenever a person has come to the primary physician with any complaints, or even otherwise, the physician can do a routine screening for detecting blood pressure. So whenever it is found that there is a high blood pressure, the necessary investigation and management can be done. Also, the primary physician can encourage lifestyle modifications for betterment and even prevention of hypertension in all his patients.
Thank you, ma'am. Can you provide an overview of the DASH, which is a dietary approach to stop hypertension regimen, and its relevance in management of hypertension?
The dietary approach to stop hypertension was a trial actually which convincingly demonstrated that over an 8-week period, a diet rich in fruits and vegetables and diet which is rich in the dietary products which are low-fat dietary products, they will help in reducing the blood pressure. This combined with a diet which was low in sodium also helps in bringing down the blood pressure. Also, the fruits and vegetables, they are rich in vitamins, potassium, magnesium, and also the dietary products are rich in calcium, which is of great benefit to the patients.
Thank you, ma'am. Moving on to my next question. So, ma'am, what are the possible adverse outcomes or let's say complications that can arise from untreated isolated systolic hypertension?
Yeah. So when a person is having hypertension and even if it is isolated systolic hypertension and it has never been treated, he can have damage to all the target organs, that is the heart, the brain, the kidneys, the peripheral blood vessels, and the eyes. He can present with heart failure. He can sometimes have ischemic coronary heart disease. As far as the brain, he can suffer from stroke, which can be either a cerebral bleed or even an ischemic stroke. Chronic kidney disease can occur, and peripheral vascular disease, and even diabetic retinopathy can occur.
Thank you, ma'am. One last question. Is it possible for ISH to occur in young individuals also?
Yes. Though we have seen that isolated systolic hypertension is a common problem in the elderly, it does happen even in the young patients And many studies have found that about 2 to 8% of the young population can have hypertension, especially those with obesity, with history of smoking and metabolic syndrome. They are prone to develop this type of hypertension even in the younger age. Also, the pathophysiology in these patients is slightly different from those in the elderly, and many a time it could be attributed to increase in the stroke volume and in the hyperkinetic circulation. So it is important to know that even this isolated systolic hypertension can occur in the youngest.
Thank you so much, ma'am. Any concluding remarks for the audience?
Yeah. On occasion of the World Hypertension Day, I would like to quote the theme of this year, that is, measure your blood pressure accurately, control it, and live longer. So, for all your patients and also to all the doctors, it is very often found that the doctors neglect their own health. So, I would ask all the doctors that please measure your blood pressure regularly, control it, and live longer and be happy.
Thank you so much, ma'am. Your expertise and contribution in putting together this informative session is very highly appreciated. And dear audience, thank you so much for your kind listening and interesting questions for the session. Stay tuned to our next lecture planned for today, 6 p.m. onwards, on hypertension in children by Dr. Munish Tomar. So we hope to see you soon. Have a great evening ahead. Thank you so much.